Hi, everyone. This is Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Welcome to the May Journal Club. We're really excited to be speaking on the topic of molecular profile is a strong predictor of the pattern of recurrence in patients with endometrial cancer. And the author of this article that we're going to be discussing, she's also a fellow, a current fellow in our journal. So I think this is the first time we actually have a journal club with a current fellow, Ana Luzarraga Aznar from Vallebron in Barcelona, Spain. We're really very excited about this discussion. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's journal club. We are recording today's discussion, and the recording will be made publicly available. Participants with cameras turned on may appear in the video recording. So we ask that everyone please keep your microphones muted so everyone can hear the presentation. And if you're having any difficulties or questions, please send a message in the chat on our technical support. Will assist. We certainly want to always encourage questions and certainly encourage participation. So now, with that introduction, Ana, thank you so much, obviously, for being with us, sharing the insights into this really important article. And we'll start with your presentation, and then we'll proceed with questions. So welcome once again, and thank you.
Thank you. Thank you very much, Pedro, for the introduction and for this great opportunity of presenting our article today. We also have online part of the research team that contributed to the article and other projects of endometrial cancer with Silvia Cabrera, which is the senior of the project. And I will start by a short presentation of the study to highlight the main outcomes. So I will share my screen. Okay. Okay, are you able to see the screen?
Yes, we can see it.
Okay, so as all we know, the molecular profile has been widely recognized for the management of endometrial cancer, and its prognostic role has been widely studied, that it is well established currently. But the recurrence pattern, according to molecular profile, has not been studied. So that's the aim of our study. Our main objectives were to investigate the pattern of first recurrence in patients with endometrial cancer according to molecular classification, and to assess the independent role of the molecular profile on the pattern of recurrence. To achieve these objectives, we performed a single-center retrospective study, and we included patients with endometrial cancer in stage 1 to 4A between 1994 and 2022. All patients underwent a primary surgery and had a complete molecular profile available. And we classified first recurrences as vaginal, pelvic, nodal, peritoneal, and distant. And we finally performed a multivariate analysis to assess the independent role of the molecular profile on each pattern of recurrence. So these are our results. We included 658 patients, of which 18.5% presented a recurrence. Of course, P53 abnormal patients were the patients that recurred the most, with more of 50% of patients presenting a recurrence, followed by non-specific molecular profile, mismatch repair deficient, and lastly, by polymutated patients with only one isolated aortic relapse. So we did not find any difference in terms of number of recurrences between molecular subgroups. Overall, 60% of recurrences were isolated and 30% were located in multiple areas with no differences between molecular profile. But we found differences in the pattern, on the pattern of recurrence of each molecular profile. P53 abnormal tumors presented mostly with peritoneal and distant recurrences, while non-specific molecular profile did with distant disease. And mismatch repair showed a tendency to locoregional relapse. And finally, in the multivariate analysis, we observed that P53 abnormal was the strongest predictor for recurrence in the overall recurrence. It was an independent predictor for distant recurrence, and it was the only independent predictor for peritoneal recurrence, which is we think something really interesting because other factors such as histological type or grade, high-grade tumors, were not independently related to peritoneal relapse. And p53 abnormal was also an independent predictor for vaginal relapse. And in the non-specific molecular subgroup was an independent predictor of distant recurrence. So we can conclude with our study that molecular subgroups presented different patterns of recurrence, and that molecular profile is a good predictor of vaginal, peritoneal, and distant recurrence. So these are the main highlights of our study. I will stop sharing.
Excellent. Okay. Thank you so much, Anna, and excellent presentation, and thank you for preparing those slides. So obviously a very important and relevant topic today. Would love to hear from you with regards to what was the rationale, what were your thoughts, what was your thinking with regards to why we should do this study?
Okay. So in fact, I think that we all know the prognostic value of the molecular profile, but we didn't know where these tumors were relapsing and also when these tumors were relapsing. And I think this is important to try to tailor adjuvant treatment, which is the main topic, I think, in endometrial cancer, with a lot of clinical trials and retrospective analysis and post-hoc analysis, and also to try to make a more a better follow-up of patients. For example, to be able to tailor which patients can benefit more from an imaging, a CT scan, for example, or which patients can benefit more for a only clinical follow-up, for example. So I think there was a gap in knowledge in this area.
Yeah. And by the way, thank you, Sylvia, for joining the Journal Club, and feel free to jump in and offer your thoughts as well. And we'll get to the questions of the fellows, but I think also, Anna, following up on your points, I think that there are many who would say, well, if you have a p53 tumor, oftentimes those tumors are related already with high risk factors that are going to lead your recommendation on the adjuvant treatment. What type of potential clinical scenario would you see where this information would really truly be of value? In other words, would that be a setting where you have a very favorable profile tumor that has a p53 mutation, and then you would say, because of this, now I need to treat it? And I think similarly, I think that we can always say the same thing for poles. The poles are, the super benign behaving. Is there a pole where you would say, I really need to treat this tumor? Particularly, I think you had 2.1% recurrence, but that recurrence was like aortic lymph node recurrence. So just would love to hear your thoughts about that.
Yes, thank you. So I think the only groups that nowadays will change or practice are the p53 abnormal tumors and the polymutated tumors, of course. Polymutated tumors, when we have a polymutated tumor, we are all happy because despite being a high grade, or despite having a deep myometric invasion, or despite having a cervical invasion, we are very confident that we can de-escalate the treatment, and we can be relatively sure that these tumors will behave as not benign, but not very aggressive tumors. And in the other hand, so for polymutated tumors, I think it's the best scenario, because p53 abnormal tumors mostly are non-endometrioid tumors that already are of high risk tumors. And mostly they are also very commonly diagnosed in advanced stages. So I think p53 abnormal tumors, maybe we have not so much benefit that in polymutated tumors.
Yeah. So we have actually already a question from one of our former fellows, Giuseppe Cucinella. Giuseppe, I see you on camera. So do you want to go ahead and proceed and ask a question yourself?
Yeah, sure. Actually, I have two questions, but it's okay. And First of all, congrats and thank you. I think there are impressive findings and this is the right direction for the endometrial cancer. My question is more about the follow-up. For sure, one clinical implication is the adjuvant treatment, and the other one is how we can modulate the follow-up for our patients based on this data. So P53, maybe they need a more intensive follow-up, and SMP as well, because they are correlated with distant relapse, and how you can coordinate this data with the totem study, where the more intensive follow-up wasn't related with was correlated with the more capacity to detect the relapse. So how you can correlate these two studies. And another question is more about the advanced disease. This is just a curiosity. If you have done a sub-analysis looking at advanced disease, and if it is true that also in the advanced disease the molecular profile can have a role, and in this sense you have one patient that is stage 4 with poly mutation, and I mean it's interesting to know if this patient with stage 4 poly, what is the story of these patients. So if the poly can have a role also in this kind of patient with advanced disease. Sorry if I've done too much question, but it's very interesting, the study. It's your fault. I mean, the results are very, very interesting. So I think you will have a lot of questions. Thank you.
Okay.
I think Giuseppe misses being in the fellowship. So he's
Yes,
asking
I think so.
all the questions that he missed through the last several months. So Anna, please proceed and answer the first of the 3 questions.
Okay, so the first question was how to tailor the follow-up for non-specific, for P53 abnormal. So of course, in our center, we haven't changed the protocol of follow-up according to this study because it's a retrospective study. But and we continue to perform the follow-up based on each patient risk of recurrence, okay? But for example, for high-risk patients, there is a closer follow-up, which typically involves a thoracic abdominopelvic CT scan, while in low-risk patients undergo a less close follow-up. However, it's true that, for example, P53 abnormal tumors presented with a higher rate of abdominal and distant recurrence that will make us more inclined to conduct imaging studies to detect these recurrences early. But as Dr. Ramirez said, this is also most of P53 abnormal patients were already high-risk patients. So I think our follow-up will not change a lot. On the other hand, for example, for non-specific molecular tumors where most recurrences were distant, well, this subgroup also constitutes a very heterogeneous group. So I think we may need to investigate other molecular factors that can help us to determine which patients in this group will benefit from closer monitoring with CT scans to detect, for example, these distant recurrences, and which patients will benefit from less intensive monitoring because they will behave less aggressively, for example, non-specific molecular profile with hormonal receptors, with positive hormonal receptors. And last, we have also to consider that even if we do not have evidence that confirms, as you said, with the totem study, that that detecting earlier recurrence improves the overall survival, maybe these patients can benefit from more local treatments that I think this will improve the disease-free survival, maybe not the overall survival, but surely the quality of life.
Excellent.
And the last question was, I forgot.
More about the advanced disease.
Yeah. So yeah, we performed the Kaplan-Meier curves. We performed them for early stage and advanced stage, and it remained the same, okay, as previously reported in other studies. And we also observed that the recurrence pattern behaves the same. And finally, for the polymutated patient, in fact, the polymutated patient that was in stage 4 was the one who recurred. So this patient was a low-grade endometrial cancer who did not receive adjuvant treatment, and she presented this aortic nodal relapse, which was treated locally with radiotherapy. and she's free of disease now. She's alive. So that's the story of a polymutated patient.
Thank you so much.
Thank you, Anna. Great start to this journal club, and we're going to get to now. We're going to get to the questions from the chat, but we'll start now with some of our questions from the fellows. Osna.
Hi, congratulations, Anna et al. For this wonderful and important publication. And just wanted to ask you, your analysis included patients who underwent surgery from 1994 to 2022. But were you able to test for poly mutations back in 1994? And if you were not able to test for those, do you think it may have introduced some bias in your analysis?
Thank you, Osnat. So for many years in our hospital, we have been conducting translational research, especially in endometrial cancer. And since the early 90s, patients have been asked for consent to use their tissue samples for research studies. This has allowed us to establish a large tissue biobank comprising both preoperative biopsy samples and also surgical specimens. And these tissues have been paraffin embedded, and it is from these stored specimens that we have retrospectively conducted complete molecular profiling in these recent years by our research team. So the molecular profiling has been performed also prospectively in the clinical setting in all patients on endometrial biopsies since 2018. And therefore, the poly status has been analyzed in all samples. And we excluded, in fact, patients with an available complete molecular profile. So we do not have patients without poly assessment. These patients were excluded from the study.
Excellent, Anna. Thank you so much. We'll go back to the chat, and I see one of our also former fellows, Alex Shushkevich from Ukraine. Alex, you want to ask your own question?
Yeah, thank you so much. And the first, I would start from congratulations. This is an amazing achievement, Anna. So congrats here. Listen, your study looks like also amazing. So this is really perfect. I just wondered, you wrote that P53 group has a peritoneal peritoneal disease. And I'm just wondering, it's like a distant disease or local disease? And if it's local disease, will this patient profit from the extent surgery procedure? What do you mean?
Okay, thank you so much for this question. So maybe at the beginning, I should explain a little bit more what kind of recurrence. So peritoneal recurrence, we mean disease in the abdominal cavity, not in the pelvic area, because this is a pelvic disease, okay? But in the abdominal cavity, carcinomatosis, okay? Outside the pelvic area. So it's not a local recurrence, of course, but it's not a distant disease for us neither. It's a peritoneal disease, it's a carcinomatosis. So for us, it's a distinct pattern of recurrence, not distant, not local. So is it still local recurrence or distant? Okay, yes, for the type of surgery, well, if you diagnose these patients with advanced stage, of course, I think they will benefit from a cytoreductive surgery. But if you mean that if they are diagnosed in an early stage, I think maybe you're meaning this, in an early stage, is they will benefit from lymphadenectomy, for example? Was this your question?
So I mean, you know, when it's like early disease, and after that you have find that this patient has a peritoneal disease, and this peritoneal disease in pelvic cavity. Yeah, is it like possible to extend our surgery procedure, because we know in advance that P53 it's like will lead us to peritoneal disease. Like
okay. Yeah, I understand. I think if you diagnose a P53 abnormal patient, for example, with a local disease, you need to perform a disease according to the early stage. So you need to make a hysterectomy, bilateral oophorectomy, biopsy, sentinel lymph node biopsy. And I think also, but this is another idea of study that we have, but we haven't data now, about the lymphadenectomy. Maybe there is a role for lymphadenectomy in this kind of patients, maybe for peritoneal biopsies. Yeah. But I think if it's an early stage, we do not have to make a more extensive surgery.
Excellent. So Anna, we'll go now to Turkey. Melis.
Thank you, Anna, for this great presentation. And my question is, why was there no inclusion of fifth group comprising multiple classifiers as recommended by ESCO guidelines?
Thank you for bringing us this interesting topic, because when we designed the study, we also considered to analyzing the pattern of recurrence of multiple classifiers, as we agree that it's a really interesting topic and there is no literature about the pattern of recurrence of these molecular subgroups. However, in this article, our main objective was to describe the pattern of recurrence according to the four molecular classification, the four molecular subgroups described in the ESCO guidelines, and also in the FIGO 2023 classification and in the WHO classification. And according to this, all endometrial cancers with more than one molecular feature can be classified into one of these four molecular subgroups. And this is the main reason for not including the multiple classifiers in this work. Before Leon Castillo's publication on multiple classifiers, there was controversy about whether the analysis of mismatch repair proteins or poly should be done first, because there was not enough literature on the subject. But after the publication of that article and the establishment of the Vancouver algorithm, the ESCO guidelines do not establish a fifth group for the for the multiple classifiers. On the contrary, they state that all patients can be allocated into one of the four groups based on the first mutational finding. But I think that a lot of data is now coming up regarding this question, and I think this is an analysis we will surely do in the future, not now.
Thank you.
Great, thank you so much, Melis, for that question. And I see we have a strong representation from Spain, so we'll start with your colleague from Spain, Rosa Montero.
Thank you, and congratulations, Anna, and your team for this paper. So my question is, do you have any data on molecular profile at recurrence? And would you consider this relevant to explore in future studies?
Thank you, Rosa. No, unfortunately, we do not have data on the molecular profile of recurrences. Although we are currently performing this analysis in the clinical setting, we do not have this information for the patients included in this study due to the retrospective nature and the fact that recurrence biopsies were not stored at that time. And as far as I know, there is not much more evidence on this topic, although I agree is a really interesting topic, because understanding whether the molecular characteristics change between the primary tumor and the recurrent tumor is particularly important for analyzing potential targeted treatments.
Great. So Anna, first of all, I want to tell you that you're doing extremely well under this rapid fire format. So you're getting a lot of questions, you're answering a lot of questions, and we really are very, very happy that you're sharing that with us. Let's turn to some of the questions on the chat. Elena Olearo, also a recent graduate from our fellowship. And Elena, I don't know if you want to ask your own question.
Yes, thank you so much. Great job, Anna. Congratulations on your study. So my question is, do you have any data about the recurrence pattern according to the surgical access? Did you notice any difference between minimal invasive surgery and laparotomy?
Thank you. So many interesting questions that we already had think with the research team, and we want to do a lot of things with that. So yes, we did not analyze in this paper, okay? In our multivariate analysis, we focused more on the type of adjuvant treatment received. However, currently, in fact, a resident is performing her PhD on molecular profile also. And one of the objectives is to analyze the pattern of recurrence according to the surgical approach and molecular profile. because since the molecular profile can be obtained preoperatively with a high concordance between the preoperative biopsy and the hysterectomy specimen, these informations will surely add knowledge on how to tailor the surgical technique and approach according to molecular profile. So it's really interesting.
Thank you so much.
Excellent. Thank you, Elena, for joining. Next, Albert Jacob. Albert, I see that you're on screen, so you want to go ahead and ask your own question.
Yeah, I'll ask the question. Great job with the study. And I wanted to know why you've excluded stage 4B patients. And I also want to know if in your analysis of patients undergoing adjuvant therapy, was there any deficiency in either of the molecular subtypes, like which had a more recurrence?
Thank you.
Okay. Thank you, Jacob. So we excluded patients in stage 4B because we think there are different, unfortunately, different type of patients. Okay, normally patients that can be operated. Also, some 4B patients can be operated, but mostly not. We think that patients in stage 1 to 4A are most likely to have no residual disease and no disease at the end of treatment. And this is more easy to analyze the pattern of recurrence of these patients than patients with stage 4B that maybe at the end of the adjuvant treatment we have disease, and it's I think it's a different type of patient. There are already metastatic patients with different prognosis, with different management. So I think it's also really interesting, but we decided not to include it to have a lower bias with the type of patients, to have more specific patients. Yeah.
Excellent. Very well. So now we'll proceed with the next question from our fellows. And Arthur is telling me it's going to be Susan. Susana?
Hi, Susan, you're on mute.
You're on mute.
Oh, sorry. Thank you. Congratulations, Anna, for your great work. I want to ask you, so given the different recurrency pattern of molecular groups, how does your institution tailor your adjuvant treatment, the sequencing of radiation, chemotherapy in high-risk endometrial cancer for each subgroup?
Thank you, Susan. So for the moment, we have not, of course, made any changes also on the type of adjuvant treatment based on our results, and we won't, since it's obviously a retrospective study with the limitations that entails. So in high-risk patients, we continue to administer the adjuvant treatment recommended by the ESGO guidelines. In stage 3 patients, we administer concurrent chemoradiotherapy following the PORTEC-3 scheme, regardless of the molecular profile, even in polymutated patients. And we use the same PORTEC-3 scheme for P53 abnormal patients with myometrial invasion, regardless of stage, given the benefit of adding chemotherapy to radiotherapy observed in the postdoc study of the PORTEC-3 in these patients. And maybe in the future, we will discuss what to do with patients with P53 abnormal with no myometrial invasion. I think it's a really interesting group with almost no data, except the recent study published by Amy Jamieson, also in the International Journal. So basically, we didn't change our management because we only changed, we do everything according to the ESGO guidelines.
Great, thank you, Anna. And even Arthur wanted to jump in on the question. So Arthur, go ahead, proceed with your question.
Thanks, Pedro. So thank you, Anna, for your great publication. And I wanted to ask you, so in SGO, the subgroup of the post-hoc analysis of GOG-258 was revealed, and it showed that there was no particular benefit in adding radiotherapy for a P53 abnormal and DMMR, but there was but adding radiation was beneficial to P53 wild type. What are your thoughts on this, since you are working on this? Thank you.
Thank you, Arthur. Thank you for bringing up this really new data. So first of all, I think that in this postdoc analysis of GOG 258, polymutation was not assessed, no? So about 7 to 10% of patients will be misclassified. It's true that given that the inclusion criteria was high-risk patient, polymutated patients, even if they are mostly high-grade tumors, they are not typically in advanced stages or non-endometrioid histotypes, so maybe it's less than a 7 or 10% of misclassified patients. So in our cohorts, more than 40% of non-specific molecular profile patients or P53 wild-type patients received external radiotherapy, and almost 40% were treated also with brachytherapy, which surely may have modified the recurrence pattern when comparing this cohort with the cohort of the GOG. Regarding the lack of benefit in mismatch repair deficiency tumors, in the postdoc analysis of the PORTEC 1 and 2 studies, this molecular subgroup also did not show a benefit from adding either external radiotherapy or brachytherapy compared to non-adjuvant treatment. Although obviously I'm aware that there are different group of patients, because PORTEC 1 and 2 are patients of intermediate and intermediate high risk, and GOG are patients of high risk. But this may say to us that mismatch repair deficient tumors are not really radio sensitive or radio resistant. And lastly, despite most recurrences in the P53 abnormal tumors in our study were distant and peritoneal, and therefore with little apparent benefit from radiotherapy, up to 14% of our patients presented nodal recurrences. So I think that radiotherapy could be beneficial in these patients, but all these data are very recent, and we will improve our tailoring of adjuvant treatment with prospective trials, with the PORTEC 4A, with the Rainbow trial. So we will see.
Excellent. So our next question will come from Natalia Palas.
Thank you, Pedro. So Anna, congratulations again. My question is on the follow-up again. So maybe you can sum it up based on your findings for every subgroup. How would you do this follow-up?
So yeah, it's almost the same answer that previously. So we did not change our follow-up protocol. Mostly P53 abnormal tumors, we do a closer follow-up with CT scan, and non-specific molecular profile, I think we need to tailor with more molecular features, more subgroups of non-specific molecular profile, because it's a really heterogeneous cohort.
Excellent. So Anna, we have a question from Nuria Agusti, and I'll read the question for her. I believe she wants to know, which is your favorite city, Madrid or Barcelona?
Of course, Barcelona, and also for Nuria. So we agree with that.
And I wonder which team did you support, Barça or Madrid?
I don't like football, so I don't care.
Another outstanding fellow from the journal, Nuria Agusti, who is of course from Barcelona, and he is now just across the street from me at MD Anderson. So Nuria.
Yeah, hello. First of all, I wanted to join in with the congratulations, Anna. I think that your team's work was really impressive, and I'm glad to see the additional evidence that you presented here. So my question was regarding the timing of recurrence for each molecular profile. Do you have any updated information in this regard?
Yes.
Yes.
Yeah, this is indeed a really interesting question, because it would be logical to assume, for example, that patients with P53 abnormal tumors, in addition to being those who recur most frequently, do so more aggressively than other molecular subgroups due to the inherent aggressiveness of these tumors. But for example, in a study published by Sig and Taylor previously, they found that it was mismatch repair deficiency tumors the ones that recurred earliest with a median of 13 months. And next, it was a P53 abnormal tumor. In our study, we did not address the time of recurrence according to molecular profile, but we are currently analyzing this outcome for a future paper. And in our cohort, it was P53 abnormal tumors that recurred earlier with a median time to recurrence of 1 year. Followed by closely by mismatch repair deficient tumors with a median time of 1.4 years, and followed by the non-specific molecular profile with the longest time to recurrence that were of 2.7 years. So indeed, I think it's really interesting to consider for the follow-up we offer to our patients in terms of performing a closer monitoring or maybe spacing them out more.
Great, thank you, Anna. And I'll just ask one additional question with regards to what's in the future in terms of your studies. What are you working on now? Anything related as a follow-up to this study?
As a follow-up, what? Sorry.
Anything related as a follow-up to this study?
Yes. Yeah. In fact, we are now currently writing an article, but don't steal the idea. No, it's a joke about about the prognosis. For example, a P53 abnormal that has a vaginal recurrence has the same prognosis that a P53 abnormal that has a distant recurrence for the fact of being P53 abnormal. I mean, does the molecular profile affect the prognosis on each location of recurrence? This is one of the things that we are analyzing. Also, the median time to recurrence, and also a lot of questions that the audience asked and the fellows about the surgical approach, and well, that's mostly our research field now.
Well, thank you so much, obviously, for sharing that with us. There's one additional question from the audience. Which mutation in NSMP group had more likely to have distant mets and need more follow-up on the NSMP group?
Okay, so the non-specific molecular profile, I think we already have some molecular features that can help us to tailor better. For example, the hormonal receptors, the L1K receptor. So I think, for example, estrogen, non-specific molecular profile tumors that have positive estrogen receptors are maybe less likely to behave aggressively. I don't know if they are less likely to make distant relapse. But in case of doing a distant relapse, we have the hormonal treatment that we know that is a good treatment for these patients.
Excellent. So Anna, thank you so much. You, and if I may have the liberty of saying, you and your baby did a fantastic job.
Thank you.
Really very proud, and congratulations. And thank you for sharing all of this information, and I hope that this next paper that you described will also come to the International Journal of Gynecological Cancer. I wanted to also thank all of you who attended the journal club, and also want to remind everybody that recording of today's session will be available on the IJGC, IGCS, and ESGO websites. And also inviting you to next month's Journal Club in June. This is going to be a discussion by Chris Harkoler and Akam Snyder on the radical vaginal trachelectomy, long-term oncologic and fertility outcomes in patients with early cervical cancer. Once again, thank you, Anna. Fantastic job. And thank you to all the fellows for submitting your questions. And thanks to the rest of your team and Sylvia and the rest of the authors.
Thank you. Bye-bye.